Hey guys, welcome to part 7. This might be a tidbit podcast because I have a lot of stuff to do and it's a bit of a busy day, so I wanted to just throw in something for you, hopefully to tide you over and help us review some topics. And today's video is, I think I'm going to cover phosphodiesterase inhibitors. So PDE inhibitors, they come in 3 flavors, 3, 4, and 5. The main ones to remember are 3 and 5. But I'll throw in 4 just for fun. There is one drug that inhibits all 3, and that's theophylline. Theophylline is used in COPD and asthma. Basically how it works is it increases CAMP in cells, and also it works as an adenosine blocker, and therefore you're kind of going to bronchodilate with those 2 actions there. PDE5 inhibitors, that's your sildenafil, tadalafil, and avanafil. So those 3 drugs, especially sildenafil, is used in erectile dysfunction, but they know that you know that, so they're going to test something different. Like, for example, their use in pulmonary hypertension. You can also use tadalafil for BPH. And how these work is they are going to increase cGMP. PDE5 works on the breakdown of cGMP. Okay. PDE3, on the other hand, works on the breakdown of CAMP. So remember that 5 is cGMP, and how that, when that increases, you're going to have increased smooth muscle relaxation, increased nitric oxide production, and vasodilation. So that's how it causes the corpus callosum to blow up, and also how it is going to improve pulmonary hypertension by allowing the pulmonary vasculature to relax. Okay. Next one is PDE4. So that's roflumilast. Roflumilast is used in severe COPD. It's kind of one of those later on agents that you throw in when you don't know what else to put in. It's a PDE4 inhibitor, and it's going to increase CAMP, similar to PDE3. And increased CAMP in the bronchioles can, also have a sort of relaxation effect on things like granulation tissue. So it'll calm down the neutrophils, it'll calm down the granulocytes, and help to stent COPD a little bit that way as well. PDE3. Now these are pretty highly tested, and they have 3 main actions. So PDE3 has 3 sites of action that are important to know about: the myocardium, the peripheral vessels, and the platelets. So if you're dealing with, for example, milrinone is a PDE3 inhibitor that works predominantly in the myocardium, and it's used for cardiac failure, cardiogenic shock. When you have an increased CAMP, you're in the heart, in the myocardium, you're going to have increased calcium channel opening, and that's going to have an ionotropic effect on the heart muscles. Also, now if we're moving into the peripheral vessels, we have things like cilostazol, dipyridamole, which have a dual action. So originally you might have learned is these drugs are used for antiplatelet effects. Increased CAMP have a anti-aggregation effect on platelets, and these are common drugs used for things like TIA and stroke, used for after coronary stenting. Cilostazol, dipyridamole are thrown in there, but they have a side effect of being useful for intermittent vascular claudication. So because of the peripheral action of high CAMP in dilating smooth muscles and relaxing vessels, they are also used for intermittent claudication, kind of as a second line. Okay, so we've went through the PDE inhibitors. I think that's a pretty solid review of them. Now let's go through another couple drug classes called the sympatholytics. Sympatholytics are blockers of alpha. So alpha 1, alpha 2 blockers, those are the important ones to know about. Alpha 1 antagonists, so that's things like doxazosin, prazosin, terazosin. Those are the main drugs there. And what doxazosin and terazosin are used for really is BPH. BPH in that they can dilate kind of the smooth muscles around the urethra and allow for the urine to bypass the prostate in BPH. Okay, so the side effects are also tested. Things like orthostatic hypotension are very common. Retrograde ejaculation, watch out for that one. Dizziness, headaches, hypotension, things that you kind of expect with alpha-1 antagonists. Prazosin is also interesting because it's not only used for things like, it's not used for things like BPH, which you'd commonly misassociate it for. It's usually mainly used for things like hypertension and PTSD. But it's not a first-line agent for hypertension, so just remember that. And prazosin, you can associate it with priapism, P and P, because if you inhibit alpha-1, inhibit sympathetics, you're going to have chronic dilation of the corpus callosum, and you can get priapism. Alpha-2 blockers, okay, so an alpha-2 antagonist that is good to know about is something like mirtazapine. It's used in depression. That's really all there is to know about it, really. It can cause some sedation, it can cause increased appetite and weight gain. So if you have someone who's depressed, who's not eating, mirtazapine can be an option for you there. The problem is it can also cause hypercholesterolemia because the person just ends up eating too much, okay, and not the right foods. Okay, non-selective alpha antagonists. So that's alpha-1 and alpha-2. That's phenoxybenzamine and phentolamine. Phenoxybenzamine is irreversible and phentolamine is reversible. The main use for phenoxybenzamine is usually pheochromocytomas. When you, before you do an operation for pheos, you want to block the alpha effects before you block the beta effects. If you do it the other way around, you're going to get really strong hypertension. So, and that can lead to problems later on. So, phenoxybenzamine is a pheo drug. Phentolamine can also be a pheo drug, but the main uses for phentolamine are things like hypertensive emergencies, tyramine emergencies, where you have a MAO inhibitor, and then you have tyramine toxicity, cocaine intoxication, and for that, even for that, it's second line. So phentolamine, not really ever used as a first line agent, but it's good to know its mechanism of action. And with both of these, you can get something called reflex tachycardia. So basically, when you antagonize cardiac alpha-2 receptors, you can cause an increase in heart rate, right? Because you're triggering a negative feedback loop after activation of the sympathetic nervous system. So you get this negative feedback, you get reflex tachycardia when you block alpha-2. Okay. Other things to know about alpha-2. So alpha-2 receptor agonists. We talked about the antagonist. Now let's talk about the agonists, because those are also sympatholytics in the case of alpha-2 if you have an agonist. So that's clonidine, guanfacine. Those are classic ADHD drugs, Tourette syndrome drugs. You can also get things like orthostatic hypotension from these, rebound hypertension from agonizing alpha-2. Alpha-2, remember, is presynaptic, so if you're going to have an agonist of it, it's going to downregulate your sympathetic response, downregulate vesicle release and things like that. Methyl dopa is used for hypertension in pregnancy. It's important to know because of its side effects. It has autoimmune hemolytic anemia as a side effect, hyperprolactinemia, and drug-induced lupus. Those three are really good test material. Tizanidine is used for things like MS, cerebral palsy, ALS, muscle spasticity, and those are the main uses there of tizanidine. Those are really the test fodder for it. Right, so we've gone through the alpha-2 agonists. Now the other sympatholytics are things like tetrabenazine and reserpine. These are not really used all that often. Reserpine actually isn't even made in the US anymore. So really you're not going to see reserpine on your test, but the mechanism here is VMAT inhibition. So if you inhibit VMAT, you're going to stop the packaging of monoamines presynaptically and eventually their release. So tetrabenazine, at least, it's used for things like hyperkinetic disorders, chorea, Huntington's, Tourette's, and tardive dyskinesia. Now, we've talked about, I don't think we've talked about tardive dyskinesia before, but it's one of those extrapyramidal symptoms, which I think we should just touch on right now so we can get a quick refresher. So the extrapyramidal symptoms are side effects of using antipsychotics or dopamine blockers, and they come in a specific order. So how I like to remember this order is through the acronym DTAP, DTAP. So that's dystonia, pseudoparkinsonism, akathisia, and tardive dyskinesia, and that goes from hours all the way to months out from the use of the drug. Okay, so let's start with acute dystonia. This is things like muscle spasms, torticollis, tongue protrusion, twisting, oculogyric crisis, where you have the eyes kind of fixed in a specific position. And how you treat this disorder in particular is you can use benztropine. So benztropine really is one of those anticholinergic drugs, and how you remember what kind of drug to use is you can remember that dopamine and acetylcholine are kind of intimately related. You want their levels to be sort of balanced out. This might not be physiologically true, but it's true in the sense of answering these kinds of questions. So if your dopamine is low, you want your acetylcholine to be low in order for you to avoid side effects. That's how you can think of it, really. So benztropine here, you can also use diphenhydramine. Those are the two main tested ones. Pseudoparkinsonism, so that's your cogwheel rigidity, your bradykinesia, your stiff gait, and your unilateral tremor. Usually it's unilateral, sometimes you'll see it bilaterally. That's not a strict rule. And that one you also use your anticholinergics, your benztropine. You can also use a dopamine agonist, amantadine, for example, if it gets worse, right? And that's 1 week out. So acute dystonia is hours to days after. Pseudoparkinsonism is 1 week. Akathisia is 1 week to 8 weeks, so it's usually months out. And tardive dyskinesia is years out. So akathisia is a sense of restlessness and urge to move. Basically, you want to use a special drug for akathisia. So I know we talked about using benztropine and diphenhydramine for the last two, but this one you want to use propranolol. The beta blocker is the best drug for akathisia. You can use benztropine also, but the first line is propranolol, and that's where they'll try to trick you, because you'll remember benztropine, diphenhydramine, but you'll forget that the first line agent for akathisia in particular is propranolol. Okay, and then tardive dyskinesia is sort of a syndrome of involuntary movements. You'll see involuntary movements of the tongues, the lip smacking, the chorionic movements in this person. That's when the side effects have gotten really bad. For this, the first line is to really discontinue your antipsychotic once you've gotten to this stage. You can give anticholinergics and a VMAT inhibitor is actually second line here. So valbenazine is the one to know. It's a VMAT inhibitor, but first line, discontinue your drug. You can give an anticholinergic to help you balance out the effects of tardive dyskinesia. So diphenhydramine in this case. Okay. So I hope this has been kind of a helpful summary of the effects of extrapyramidal symptoms. Okay, and the last thing we can start talking about, I think, actually, while we're on extrapyramidal symptoms, let's talk about neuroleptic malignant syndrome. I think it's a good tie-in here. Okay, so neuroleptic malignant syndrome is one of those life-threatening syndromes that's associated with antipsychotics, and it's characterized by really a tetrad or 4 findings that are very important: fever, muscle rigidity, autonomic instability, and mental status changes, as well as rhabdomyolysis, elevated CK. Those things are important to remember. And it's really a reaction to antipsychotic drugs. Other agents that affect the CNS can also be involved, like lithium, venlafaxine. Antiemetics can also push it forward. And usually these people have a genetic predisposition to developing it. So the pathophysiology is related to central D2 blockade in the nigrostriatal pathway, which results in kind of a movement disorder and impaired thermoregulation. And so you'll see the muscle rigidity, like we talked about. Hyperthermia is very key to remember. Increased CK. Leukocytosis can also be seen, along with metabolic acidosis. Things myoglobinuria is important here. And that's one thing that you need to remember, is that when you treat this, you're going to treat it with discontinuing the antipsychotic first, and then always discontinue. If you get the answer of discontinuing a drug, a good chunk of the time it's going to be the right answer. So you can use pharmacotherapy to kind of help you with this. Dantrolene is one of the mainstays here if the condition is not calming down usually on its own. You can also add on things like bromocriptine or benzodiazepine if it persists even after you've discontinued the drug and you've kind of hydrated and kept the person under close watch for kind of any respiratory arrest or things like that. Okay, so that's neuroleptic malignant syndrome. Basically, it's an antipsychotic blockade side effect where you have severe hyperthermia, muscle rigidity, increased CK, and that's different from, usually they'll give you the antipsychotic in the question stem, and it's going to be different for something like a serotonin syndrome where they'll give you the SSRI in the question stem. They have to be pretty mean to make you differentiate it entirely based on the symptoms, but actually in the next podcast, I'll go into the symptomatic difference between neuroleptic malignant and serotonin, because I think it'll be high yield. Just don't have time today, so we'll pop into that topic next podcast, and I'll see you guys in the next one.